Hi,
Inshallah,
greetings
inshallah.
everyone. Welcome to MeForm 2021, Expanding Knowledge and Meeting Challenges, 5th to 7th April 2021. I wish to thank the organizers, especially Dr. Mashari from Kuwait, for inviting me for this presentation. This is part 2, where I will talk about the PETCT imaging of yttrium 90 injected in hepatic carcinoma patients. On the use of yttrium 90 microsphere imaging. The clinical relevance of yttrium 90 PET-CT after SIRT yttrium 90 for HCC, unresectable HCC, will be looked at, and we need to know, was it technically successful, the procedure? That is the radiation biodistribution according to planned expectations, or is there any non-target activity, location of yttrium 90 in non-target areas? What are the radiation safety limits if there are, and whether there's a need to do a repeat SIRT. So these are images obtained from Singapore General Hospital. We have been using yttrium 90 SIRT for HCC, unresectable HCC, for more than 10 years. Yttrium 90 microsphere imaging, basically, it's a beta emitter. That means yttrium 90 emits beta, and 99.98% of the time it reaches zirconium 90, and very rarely, actually, it produces a minimal internal pair production, about 32 parts per million of positrons emitters, and this is the component that is useful for PET-CT imaging. Conventional imaging with yttrium 90 with a gamma camera or SPECT-CT scanner, beta radiation from the yttrium 90 in the tissue results in the Bremsstrahlung radiation, and the Bremsstrahlung X-rays scatter off the lead collimator of the gamma camera, and giving rise to lead K characteristic X-rays at about 80 keV. So that can be seen on the graph on the right hand side. The gamma scanner energy window is centered at the lead K characteristic peak for imaging, and this peak is broad with low counts, unfortunately. Hence, resolution and lesion detectability is poor, as image is made from Bremsstrahlung radiation, and which is poor in energy res. Secondary scattered radiation from the lead collimator results in poor spatial resolution as well. So this continuous spectrum can be seen. Now, let's look briefly at the history of yttrium 90 PET. Back in 1955, when it was actually discovered, yttrium 90 and how it decays, and then in 2005, assaying and PET imaging of yttrium 90 was done. As early as that, and we talked about this 34 parts per million, and this is actually a cross-sectional view of the Jezek Phantom. And back in 2009, and pretty much close to when Singapore General Hospital also started doing this yttrium 90 time of flight in 2011. Yttrium 90 TOF PET scan demonstrates high resolution biodistribution after liver SIRT. So the PET imaging for yttrium 90, the good points are the better resolution from Bremsstrahlung compared to Bremsstrahlung imaging, co-incident gamma photons corrected for attenuation, potential for quantification was better, an actual absorbed dose calculation can be done, and much higher pixel resolution compared to Bremsstrahlung imaging using SPECT. The bad points, of course, was, as you would correctly suspect, we have 32 or 34 parts per million of internal pair production. It's a small amount of positron emission. Hence, the amount of time taken for bit frame will be long. Poor counts rates, poor signal to noise ratio as well, and long acquisition time, typically 30 minutes per bit position. And that is not something that all patients can be subjected to, especially patients who are ill and in pain, and perhaps even the elderly. So Is yttrium 90 PET useful? Well, it helps in this upper arm is the qualitative accuracy of the yttrium 90, localization of the yttrium 90, helps us, as I mentioned in slide 2, targeting appropriateness, technical inaccuracies, and helps us to predict future tumor response. Well, quantitatively, it helps us with the dosimetry aspect, post-treatment dosimetry, and intertumoral distribution as well. These are images from my hospital back in 2012, 2011. Yttrium 90 has superior spatial resolution. As you can see, this is a SPECT Bremsstrahlung image on a SPECT CT. The yttrium 90 can be seen as big clumpy, but on PET, you can see them as separate places. The biodistribution can be accurately determined as well. Now, superior spatial resolution also helps us to confirm successful implantation, as well, as you can see in this note here, but cannot be seen on the Bremsstrahlung SPECT CT scan. The superior spatial res also confirms the absence of radioactivity as well. As can you see, this portion here, we can't really very sure whether the radioactivity exists, but you can see very clearly in yttrium 90 PET-CT that it is not present. Predicting future response, better localization of microspheres, allows for better prediction of future response to treatment, and also helps us to determine portal vein tumor thrombosis, which is localized by yttrium 90 PET, but not by Bremsstrahlung SPECT CT, as can be seen here. Due to better resolution of yttrium 90 PET and the excellent attenuation correction in PET-CT, quantitative analysis can be performed for absorbed dosimetry. There were two methods I described here. The first method was actually by our hospital, the count base with reference to a standard activity of a yttrium 90, and the other is from a Hong Kong group, which is count base with image convolution with yttrium 90 voxel dose kernel using Monte Carlo. The use of yttrium 90 PET-CT for yttrium 90 dosimetry is described in this page. This is the work done in my hospital. You would correctly recognize this insert that is used in one of the Tomo Phantoms. What we did was we placed a yttrium 90 residual activity in a vial, a glass vial with a cap at the top, and it can be seen on this transverse view. The standard yttrium 90 activity was assayed in a calibrated dose calibrator, and that is on the x-axis, and the y-axis is the yttrium 90 radioactivity obtained from voxel assessment on the PET-CT, and you can see there's a linear relationship between them. So we could actually accurately predict the radioactivity that is measured by the gold standard dose calibrator. So the linear correlation with the vial activity measured in a dose calibrator was performed, and counts are directly correlated to dose activity. Voxel counts are obtained from the PET image, decay corrected counts are obtained, voxel volume and lesion volume are also obtained. Radioactivity is estimated through the standard source in comparison to the standard source, and the linearity of the counts per megabecquerels, as was proven in the earlier slide, based on a 50 gray kilogram per gigabecquerel of energy deposited using the radioactivity and lesional volume. The absorbed dose can be calculated. The recommendations are for imaging is time of flight is necessary to improve the signal to noise ratio. As you know, we are talking about a very low number of parts per million of this internal conversion. Iterative reconstruction with fewer iterations possible. Intrinsic noise from the LSO crystal is noted, but some papers actually use BGO, which doesn't have the LSO crystal noise. Longer time of acquisition, as I mentioned, 30 minutes per bed frame, and these are some other references. We actually have a poster at eNets a few years ago, which actually we published the optimizing reconstruction algorithm to improve image quality of post PRRT yttrium-90 scan. And the reconstruction method, the filter cutoff was 5 mm, Z-axis filter, etc. So this is basically what we use in our yttrium-90 PET. In summary, I wish to say that the yttrium-90 PET is clinically useful in certain situations and qualitatively allows for more precise localization, vivid localization as well, and targeting identification of technical inaccuracies, and also helps us to predict future response of the yttrium-90 therapy. Quantitatively allows for post-treatment dosimetry to determine accurate absorbed dose and to estimate intratumoral absorbed doses due to tumor heterogeneity, facilitating prediction of responses to tumor. Now, it also helps to improve the PET's imaging application to dosimetry, which is still works in progress, and there's still much to do. So